Hello, welcome to the DIO webinar. I'm Professor Byungho Choi at the Yonsei University in Korea. Today, you will be watching live surgery, which is about full arch restoration. First, let me introduce the patient for the live surgery. She had many teeth problems in the mouth. First is she wanted to get lower teeth problems fixed. Look at the remaining teeth. Had a severe periodontitis. We decided to remove all the remaining teeth in the mandible. She wanted to get a fixed prosthesis using implants rather than an overdenture. And then we decided to do Oron 6 implant treatment. Look at the remaining teeth. You can see here some bone loss around the teeth, remaining teeth. To do implant planning, we put intraoral markers on the alveolar crest. We took intraoral scan images and CBCT scans. We merged two digital images. On the merged image, we did Oron 6 implant planning. It was possible to position all 6 implants in the mandible without bone graft. We decided to cut the bone at this level. The treatment plan we established was Oron 6 implant placement, bone reduction, and immediate restoration. On the merged image, we designed a bone reduction guide, a top part and a foundation part. This shows the foundation part. You can cut the bone using the foundation part. This shows the cutting level of the bone reduction. This shows a surgical guide designed, which is connected to the foundation part. 3D printed top part and printed foundation part. Printed surgical guide part. We prepared a provisional denture to do immediate restoration. We fabricate it using a 3D printer. We also prepared titanium temporary cylinders and rubber dam sheets. Now we are ready to perform Oron 6 implant placement, bone reduction, and immediate restoration. Let's move on to live surgery. We performed the surgery under general anesthesia because the patient was afraid of the operation. Another reason was severe bleeding could occur during bone reduction. It's easier to control the bleeding under general anesthesia. The mandible is exposed on the labial side, and this is the bone reduction guide. The bone reduction guide is placed in the mouth. This is an anchor drill. with a low-speed drilling without irrigation. This is an anchor screw is placed to fix the foundation part. You can see here low-speed drilling without irrigation. The speed is 100 RPM. The second anchor screw to fix the foundation part. The top part is removed by pulling it out. My left index finger is located on the ringer side to get a sense of the sewing, to protect the ringer mucosa. And the bone segment is removed. The surgical guide part is now connected to the foundation part of the bone reduction guide. Another anchor drilling for anchor screw to fix the surgical guide part. The drilling is also a low-speed drilling without irrigation. In between, saline irrigation is done into the osteotomy site. This anchor screw is to fix the surgical guide part. Another anchor screw to fix the surgical guide part. Irrigation is done to remove the debris and to cool the site. Two anchor screws are used to fix the foundation part. Another two anchor screws are used to fix the surgical guide part. This is the first drill, which is 2.0 millimeter in diameter and 5 millimeter in length. The drill uses a guide tube. The drill speed is also 100 RPM. In between, the osteotomy site is irrigated to remove bone debris and cool the site. The first drill is the most important one to drill, because if there is an error in the first one, there would be errors in the rest of them. Therefore, you should be careful to drill the first drill precisely. The drill tube is tied up with a thread to prevent dropping it down patient's throat. You can see here, prior to rotating, I tried to get a sense of direction. After get a sense of direction, I started drilling. The first drill is very important. If the drill axis is created inside the bone, it is very difficult to be changed or to be corrected. The next drill is 2.7 millimeter in diameter and 5 millimeter in length. The drilling is a low speed with 100 RPM. Now we are increasing the diameter of the drill and the length of the drills. we are increasing the length and diameter gradually. This is a bone profile drill. You can control the depth of drill using the marker. The implant is placed with a speed of 30 RPM, with a torque of 30 Newton centimeters. Once it is fixed with a 30 Newton centimeter torque, I increase the torque. I got a sense of initial strong stability of the implant. I got also a strong initial implant stability of the second implant. The third implant in the molar area, I got a severe torque. You see here, placing the implant with a ratchet. I got a severe torque. The severe torque was released by counter-rotating the implant connector. I got difficulty in removing the implant connector. I use this crown remover to take it out. And then we moved to the other side of the mandible to drill and place implant. The drilling on the other side is being done using the same drill sequence as on the previous side. I got a strong initial implant stability of this implant as well. This implant as well, I got a strong initial implant stability. All 6 implants had a strong initial stability, which is about higher than 40 Newton centimeters. After placing the implant, anchor screws are removed. All implants were placed precisely within the alveolus. And then straight abutments are connected to the implants. After connecting the abutment, I check out whether the abutment cup height is appropriate or not. If it is not, you can change it. Whenever I connected the abutment, I checked the level of the abutment. The shoulder of the abutment should be above the mucosa level. The abutments are tightened up to 30 Newton centimeters. all abutments are fixed with a torque of 30 Newton centimeters. And then the temporary cylinders are connected to the apartment. The cylinders are slightly tightened by a hand. After suturing, rubber dam sheets are placed beneath the cylinders. And then the provisional denture is placed in the mouth. And check out whether the denture is placed in the right position by checking the occlusion with the opposite teeth. Acrylic resin is injected around the cylinders in the canine areas on both sides. And then the right-curing resin is polymerized while ensuring the occlusal relationship with the opposite teeth. After bonding cylinders in the canine areas, the cylinders in other areas are bonded. After polymerizing the resin, the provisional denture is removed by unscrewing the screws. And I check out whether the cylinders are secured in place. The patient was taken to the recovery room after the operation. And then we start the laboratory work, converting the provisional denture to the provisional fixed bridge. We started the operation in the morning. In the afternoon, when the patient was fully recovered from the general anesthesia, we placed the provisional fixed bridge in the patient's mouth. You can see here the provisional prosthesis immediately after the placement. And we did scanning the provisional prosthesis. You can get this intraoral image by scanning the provisional prosthesis, the opposite teeth, the edentulous ridge, and bite scan. Using the image, you can design the next one. After taking this intraoral image, the patient was discharged from the hospital. We started designing the second provisional prosthesis. The patient wanted to get long crown, long teeth. Therefore, we fabricated the second provisional prosthesis having long teeth by milling PMMA blocks. 1 week later, 1 week after the operation, we removed the sutures and placed the second provisional prosthesis in the patient's mouth. This is the second provisional prosthesis placed in the patient's mouth. 6 implants were placed as planned. Look at here, before and 1 week after the operation. She was happy with the prosthesis. 3 months later, we are going to make a final prosthesis for the patient. Thank you very much for your attention. I hope you enjoyed today's live surgery. See you. I hope we will meet again soon. Thank you very much. Bye-bye.